everyone, this is Dr. Simone Atkinson, and today we are going to study pyloric stenosis. As the triage nurse in the emergency department, you encounter parents with their 6-week-old infant. Now, the mother expresses concerns about the infant's health, mentioning frequent vomiting, weight loss, consistent hunger, and persistent fussiness. Now, the child has been breastfed, and the couple, they're homeless, they're living in their car, and they've had no primary care for the infant since discharge after the delivery. What additional information will be important now for the nurse to obtain from the parents to assess the infant's condition adequately? First, the infant's birth weight and history of the status at delivery. This will help to identify initial health status and potential predispositions that the infant may have inherited. The eating patterns, the frequency of the feeding, the duration of each feeding. So if vomiting is correlating with feeding, this is a hallmark sign of pyloric stenosis. Then the assessment of the emesis patterns. What's the frequency? What is the amount? That's going to help confirm the diagnosis as well as monitor for the severity. Diaper output and stool characteristics. Knowing the number of wet diapers, the color, the amount, and the consistency of the infant's stools. So this will indicate the hydration status as well as the gastrointestinal function of the infant. The infant's exposure to any illnesses or infections, the presence of a fever or any other symptoms, that'll help to rule out if there are any other potential causes of the vomiting. And then the mother's eating pattern, the family history of food intolerances or allergies and immunization status. So that will provide a context for the overall health now of the infant and will identify again any other potential predispositions to the current problem. So upon assessment, the infant is alert but fussy. This is indicating some form of discomfort or distress. The anterior fontanelle is slightly depressed, which could indicate dehydration, while the posterior fontanelle cannot be palpated, but this is normal in a 6-week-old infant. The infant has regular breath sounds with a normal rate of 18 breaths per minute. There are no adventitious sounds. The pulse oximetry is 98% on room air, and that's indicating adequate oxygenation. The heart rate is 140 beats per minute with a regular rhythm. They have a brachial and pedal pulses are +3 and equal, indicating very good peripheral perfusion. The abdomen is round and non-tended to palpation. They have positive bowel sounds, and the nurse notices peristaltic waves as well. The diaper is currently dry, suggesting inadequate urine output. And neurologically, the infant moves all extremities and there are no rashes noted, indicating a pretty much normal neurologic function. The rectal temperature is 98.9 degrees Fahrenheit, which is 37.2 degrees Celsius, which is within the normal range. And there is a quarter-sized flat red area on the occiput. This has been present since birth, and there's a slight tenting that's noted of the skin, indicating possible dehydration. As the nurse transports the infant to radiology, the infant vomits a large amount of clear fluid, again indicating gastrointestinal distress. And the infant's symptoms, which include the vomiting, the weight loss, fussiness, the dehydration, and the depression of the fontanelles and the dry diapers, these are all concerning for dehydration and probably pyloric stenosis. So further evaluation is going to be needed. We'll need an ultrasound to confirm the diagnosis and initiate appropriate treatment for the infant. And as the nurse, we would have to continue to monitor the hydration status, the electrolyte status very closely, and inform the parents and give them education regarding the infant's condition and what we will be doing to manage them. So based on the assessment described, which body systems would you mark as abnormal as you document your findings? So neurologic, the anterior fontanelle was slightly depressed. That could indicate dehydration. Just remember that the absent posterior fontanelle is a normal finding at 6 months of age. Cardiovascular, the child was tachycardic at 140 beats per minute. That could be caused by dehydration or just the irritability. The GI system. Now, the infant had emesis ×1 following a Pedialyte trial while they were on their way to the radiology department. The nurse also noted peristaltic waves on the abdomen, and we might want to also determine the last time the infant had a bowel movement. GU-wise, the diaper was dry. There was nothing in the output to be noted at this time. So noting the output is important because we are considering dehydration at this time. Now the skin, there were no rashes, but there was a reddened area noted on the occiput. And then psychosocially, the mother is at the bedside. She's concerned about the infant status. So we may want to consider a social work consultation for coping for this family. And for pain status, the infant is irritable even though they are being consoled. So you may want to consider at this time an age-related pain score that's allowed by the institution, for example, the FLAC scale. So what causes pyloric stenosis in infants? Well, it's a narrowing or an obstruction of the pyloric sphincter. It's caused by hypertrophy and hypoplasia of the pylorus. And there's inflammation and edema that can reduce the size of the opening until there is complete obstruction. So the attending physician has requested various tests, including a complete blood count, complete metabolic profile, urinalysis, blood pH, as well as an X-ray. Now, given the suspicion of dehydration and metabolic alkalosis that we know is related to hypertrophic pyloric stenosis, which of the following laboratory results would you align with metabolic alkalosis? And the correct answer is A, a sodium of 129, potassium of 3.6, a chloride of 89, and a bicarb level of 27. Because a common finding with hypertrophic pyloric stenosis is hypochloremia. And in A, the chloride is 89. Hypokalemic metabolic alkalosis is also expected. So low potassium, there's a 3.6 in answer A. And metabolic alkalosis, because the bicarb level is 27 in answer A. And a high level of bicarb is correlating with alkalosis. So these are all findings that would be reflected: low sodium, potassium, and chloride levels, and an elevated bicarbonate level. So therefore, the option A is best because that corresponds to the expected laboratory findings that we would see with metabolic alkalosis in this context. So what factors contribute to the development of metabolic alkalosis in this client's case? Well, the metabolic alkalosis arises due to an imbalance in metabolic acids. This is prompted because the client is recurrently vomiting after their feedings, reducing the gastric acid content, leading to metabolic alkalosis. So what manifestations are associated with metabolic alkalosis? Well, metabolic alkalosis often has neurological symptoms such as nervousness, tingling, overexcitability, and even tetany. And this can escalate even to seizures. So clients with pre-existing epilepsy, they're often very particularly vulnerable to seizure activity if they have metabolic alkalosis. So we would see increased neuromuscular irritability and tetany as key characteristic features with metabolic alkalosis. So what additional assessment findings might you expect to see as a consequence of the frequent and the prolonged vomiting in this infant? Well, continued irritability, weight loss, decreased urine output, dry mucous membranes, and lack of tearing, not being able to cry because of the dehydration. Sunken fontanelles, that's going to depend again on the infant's age. At 6 months, remember the posterior fontanelle is closed, but the anterior would still be open. They would have poor skin turgor. That could be another thing that's affected by their nutritional status if they're not able to keep down any fluids. Lethargy. Lethargy can change to coma. We may see esophageal bleeding begin. The child would be in pain. They would have esophageal pain. Their blood pressure would eventually decrease because of the loss of volume if they're dehydrated. Now, their pulse can change. They would have a change in pulse from being rapid initially because they're dehydrated. They become tachycardic to compensate, but eventually that could lead to a weak to a non-palpable pulse. And we would see that heart rate fluctuate and change as the dehydration progresses. So the physician confirms the infant with hypertrophic pyloric stenosis as the diagnosis, and the infant is admitted to the pediatric unit and they're scheduled for surgery. How would you respond to the parents' concerns about their living situation, being homeless, that's contributing to the diagnosis of hypertrophic pyloric stenosis? Well, hypertrophic pyloric stenosis is more common in firstborn Caucasian males and can be polygenic with an increased risk of occurrence in siblings and other offspring. So the exact cause, though, of pyloric stenosis is truly not fully understood. Now, the condition usually develops over the first few weeks of life as the pyloric sphincter becomes increasingly hypertrophied. And the prolonged vomiting can lead to dehydration, a failure to thrive, regardless of the living situation. So the parents are not contributing to the progression of the condition because it is idiopathic. So we want to acknowledge and support their concern. We want to explore if there was a history of family members with similar manifestations, and we will offer to contact a social worker so that they can explore any resources available to them following discharge. So what are your responsibilities as the nurse when you're responding to the parents' questions about the necessity of surgery and what will be done next? So we want to verify that the infant's parents understand the purpose and the basics of the surgical procedure. We would notify the medical team to clarify any questions the parents might have and ensure they sign the appropriate consent form. We would provide education regarding the nursing care post-operatively that we will be implementing, and we would offer support to lessen any anxiety and fears. Now, we would get the social services involved, like we said, immediately to address any financial concerns that the family may have, and we would then complete the admission process, take vital signs, continue monitoring the client, and carry out any medical orders. Which preoperative orders should the nurse question? Vital signs Q4 hours, strict INOs, 30 milliliters Pedialyte, Q3 hours PO, D5.5 normal saline at 50 milliliters per hour, an NG tube to low continuous wall suction, or daily weights. 30 milliliter Pedialyte Q3 hours PO. And why? Well, the infant is scheduled for surgery and should be NPO, nothing by mouth for surgery. Therefore, the Pedialyte is inappropriate and should be held at this time. So what types of interventions can be delegated to the nursing assistive personnel or the unlicensed personnel for the care of this infant? So first, the nurse cannot have the UAP teach parents anything. So they cannot teach parents the rationale for the NG tube insertion. However, they can remind the parents to save diapers to be weighed. They can obtain vital signs every 4 hours and report any abnormal findings to the RN. And they can assist the parents in holding the infant to prevent accidental removal of the NG tube. And another thing they cannot do would be to assess for NG tube placement every shift. So keep in mind with NCLEX, just remember, do not delegate what you can eat. And eat refers to what you can evaluate, what you can assess, and what you can teach as a nurse. So those things are not able to be delegated to a UAP. Now, what post-operative teaching would you need to provide regarding the child's feeding schedule? Well, first, the child should be NPO for up to 24 hours post-surgery. So they will not be allowed to eat or drink for those first 24 hours. We want to give the body time to recover and prevent any complications from the surgery. They'll need IV fluids for hydration. So IV fluids will be given just to ensure that hydration status remains intact while they're NPO. Pain medications are going to be needed for comfort, will alleviate any pain that they're experiencing from the surgical procedure. They will still have an NG tube for a short period of time temporarily to continue to decompress the stomach, but usually the NG tube is removed shortly after the surgical procedure. We will start clear liquids first with feedings. We'll have a slow initiation of feedings after the surgery. We want to reintroduce feedings gradually, starting with small amounts of clear liquids like Pedialyte, because we don't want to overwhelm the digestive system. Now, we can still expect vomiting. Vomiting should be expected to diminish, however. It'll diminish, there'll be vomiting initially, and then we should see a decrease in a resolution of vomiting within 48 to 72 hours after the child's body starts to adjust in the post-operative period. And finally, what guidance would you as the nurse offer to the mother regarding breastfeeding post-surgery? So if it is tolerated, the mother can pump breast milk for the child, but initially feeding at the breast might not be indicated. And the reason is we want to limit the intake the child is having initially. We said we would start feeding slowly and progress over time if they're tolerating the fluid intake. So therefore, breastfeeding initially might not be indicated, but later on, as the child is recovering and doing well and tolerating feedings, then we would revert back to breastfeeding. So that is all for now. Please like and subscribe to the channel and share with your nursing colleagues. I would also love to hear from you. So please leave a comment and let me know what other topics you would like me to cover next. We'll see you in the next video.